All right, so good morning again, everyone, and welcome to our second EHE Regional Learning Collaborative session. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPS. It looks like we have nearly 200 folks joining us today from across California's EHE Phase 1 counties and beyond. And it's just so wonderful to see all of you here. Please do take a moment to introduce yourself to the group by sharing your name and your affiliation or organization, and also your location in the chat. So I'm really looking forward to today's session on strategies for community engagement and mobilization, which is co-hosted by our amazing partners from the Prevention Through Active Community Engagement, or PACE program. We'll begin with a presentation on the integral role community engagement plays in the EHE initiative and some highlights of some of the community engagement work going on across our EHE Phase 1 counties. And we'll have a brief opportunity for Q&A right after. And then we'll move into a facilitated panel discussion with some wonderful partners doing work to engage some of our communities most impacted by HIV across our California EHE Phase 1 counties. So I just wanted to note here at the beginning of the session that you are free to enter any questions you have throughout the session using the Q&A function. You should see a little Q&A function with kind of speaker bubbles on your control panel, your Zoom control panel. So feel free to enter questions anytime. And also we will be recording today's session, and we'll be posting the recording on the CHIPS website after the session. So, feel free to reference it there and to share it with anyone who might not have been able to make the session. So now we'll move into our first presentation. I'd like to introduce Leroy Blea, who is a senior public health consultant with Vicente Consulting. Welcome, Leroy.
So, good morning. Thank you so much for having me. And I'm honored to actually participate in this panel today. And of course, I want to thank our partners at CDPH and also PACE and the steering committees of all the community counties that were part of developing their EHE plans. Their work and the work of their partners and the work of the communities in those counties could.
Oh, Leroy, I think you just were muted for a second. Would you mind
okay.
Just your last few sentences?
Unmuted again. So in repeating, I'm thanking the partners that actually participated in ending the epidemic over the course of the last accelerated planning year. I'm going to be highlighting their work and highlighting the work of their partners to focus on community engagement within the Ending the Epidemic initiative. So once again, my name is Leroy Blea. I work for Vicente Consulting. Vicente Consulting was hired by the state of California to assist in the strategic planning and the plan writing of ending the epidemic plans in each of the communities that were part of the California consortium, including Alameda, Orange, Riverside, Sacramento, San Bernardino, and San Diego. So let me see, I'm going to move on to our next slide, please. Just to, this is a graphic that you've seen a lot, of course, but to introduce the topic of how community engagement was integral into the Ending the Epidemic process is, of course, reviewing the initiative, Ending the HIV Epidemic, a Plan for America, whose overall goal was to accelerate getting to zero in each of these communities, high impact communities across the country and also in California. The goal is overall to reduce new HIV infections by 75% in 5 years and by 90% in 10 years. It was an exciting process over the last year, deadlines and also COVID-19, and we'll be talking about how that impacted overall the work. But the guidelines or the guidance that the CDC put out had some key aspects of the plans that were to be created in each of the counties, including that community engagement be a critical part of the planning process, that there be a recent epidemiological snapshot, looking at the most recent data available, which was 2018, that there be a situational analysis that really is a high-level story of HIV in the community at this point, and then also a plan section describing innovative and disruptive interventions that were meant to accelerate and getting to zero in each of the communities that we worked with over the last year. Next slide, please. So the community engagement focus initially in planning, we're focused on two simple questions. One, what should we do to end the epidemic in our community? And two, how should we do it? And of course, embedded in those questions are a lot of complexity, because the counties went through a process of developing priority populations. They went through a process of developing key interventions that were linked to the best tools available at the time. And of course, so the questions are deceptively simple. There was a lot of work that went into developing these questions and planning to answer them. Next slide, please. Of course, then COVID-19 happened. So we have described in the plans community engagement both before and during COVID-19, and we hope in an update someday to describe community engagement after COVID-19. But to talk briefly about some of the successes that happened over the course of the accelerated planning year, these included successful engagement of the planning councils. So the planning councils in each one of the phase 1 counties were integral in setting up guidance and providing input to us as we began the planning year, and also in reviewing drafts of the document and ultimately providing concurrence for each one of the counties that were for their Ending the Epidemic plans. There were a lot of leveraged partnerships. So when we began, we knew that we were going to have to work with community-based organizations that had access to the priority populations that were going to be selected. And a quick note on priority populations across the counties, but the counties have already presented to you both their priority populations, their interventions, and also the framework of what their interventions look like. So I'm not going to be so much detailing that, but actually doing a high-level overview of that. So these leveraged partnerships were critical. They continue to be critical, and I'll be talking about some examples of how those leveraged partnerships were used in partnership with other organizations to basically create forums to accelerate our community engagement process in connections with communities where we didn't have to build relationships. Relationships already existed. There was a lot of early community engagement. One of the hallmarks of this process over the last year was an early deadline set by the CDC, where a first draft had to be submitted by December, the end of December of last year. It really forced the counties and the communities to have early conversations and to do some early forums. And a number of the counties actually did multiple forums before even the end of 2019. There was connecting to new partners and new voices as one of the values of this accelerated planning year, was to try to create new relationships out of sector. So it wasn't just HIV providers, but also providers from education, from law enforcement. So we saw examples in the counties where these new partnerships were leveraged as part of the conversations that developed the plans. There was also a successful process of selecting interventions with key input from stakeholders. So what is present in the interventions were created with input from community. And I think that there are definitely tools like PrEP expansion of testing. There were some basic, things that we discussed within pillars, but how those interventions are to be rolled out definitely was informed by community. And you'll see in the way that we talk about some of the interventions, how community provided input there. There was also the necessity of pivoting to COVID-19 response. So the counties didn't stop their work doing community engagement, but they instead actually worked with us and worked with other technical assistance providers to actually create some forums virtually. And at the beginning of this process, it was difficult, as all of you kind of probably experienced yourself, that technology is as good as technology is, and that a lot of the best community engagement is able to be done face to face. But we're able to work with providers that were learning themselves how to provide support services to their clients, and where there were existing support groups, we actually went in with some community engagement questions in order to enrich the plans in certain communities. So virtual community engagement is something that's definitely possible. I'm going to be listening intently to examples from our panelists today, and it will definitely be critical as we update and think about implementing the planned activities across the counties. Next slide, please. So the selected community engagement methods, I'm not going to go over this in detail. Certainly for Alameda County, Dr. Sophie Wong is here and she'll be able to talk about what East Bay Getting to Zero Collaborative in Alameda and Contra counties were able to do. Orange County had an early town hall where community and providers came together. They had a successful implementation of the online survey that particularly reached some Spanish speakers. In Riverside County, and San Bernardino County, there were a series of community caucuses where not only were the county was able to partner with True Evolution and other community-based organizations to have conversations with both Spanish-speaking and English-speaking clients from a variety of backgrounds. We were able to go back into those communities and actually reflect some of that data back just to confirm that we heard correctly what they were telling us. Sacramento County had a really successful implementation of their online survey, distributing it through social media networks. And also they had some early community forums that were done before the end of the year. I already spoke about San Bernardino. San Diego has an ongoing Getting to Zero activities. They have actually their plans that are in place that predated the accelerated planning year. And so we were just able to update some of those plans. But they have a wonderful Getting to Zero collaborative that worked with their planning council to develop a consumer voices survey that reached over 100 individuals. Next slide, please. So the interventions, this is just mentioning some selected interventions and how they impacted what is going to be ultimately done in the counties as part of ending the epidemic. We have 3 of the counties that are going to be having some mobile van services, which is not just about HIV, but because of community input, it's kind of a wellness model. Something that also will destigmatize the activities. So it's not just HIV alone services, but a variety of services will be offered and deployed to areas in these counties where there are not a lot of services, so where infrastructure is light. And so there is a theme of actually providing services where Nova Services currently provide, and we got input from community and also by reviewing regional data to figure out exactly where in the plan those services should go. There's a sort of a testing everywhere strategy that was discussed across all of the communities, including increasing the routine opt-out testing, a more focused use of testing resources on priority populations, and also piloting home testing for both HIV and STIs, but also through building healthy online communities. Also, some of the counties are using their own resources to enhance what BHOC is doing to pilot home testing for MSM across the communities. Both PrEP and linkage to care as interventions were improved by including by the clear direction of community to include peers as part of those interventions. So peer navigators and PrEP navigators will be important to provide support and a linkage to really understanding for community that have not been well served by baseline HIV and prevention and care services, but peers can be a good bridge for that, according to our community output. Next steps, next slide, please. And just to wrap up quickly, our next steps for our project are to build out these interventions linked to priority populations. So we're going to continue doing community engagement. And I think that this forum is a unique opportunity to share and learn how to connect to community through new media. COVID-19 is going to be with us for a while. And so we're looking forward to hearing what your learnings are so that we can incorporate them in our process and make sure that as we implement the interventions in each one of the counties do that with community engagement, and we learn more and more. We get a chance to update the plans as we know more. And the other thing that we've been hearing back from community is that the plans, they're very long. They need to be made more accessible to communities. So we're looking at creating 2-page summaries of the plans that will allow them to be much more accessible to communities across the counties. Also, we want to loop back to certain communities that we weren't really able to reach as part of our community engagement process. One of those is sort of reentry individuals, so subpopulations of the populations that are the main populations of focus in each one of the counties. There's certain communities that are certainly part of the situational analysis that aren't listed as the main focus populations, but are certainly included in the concept of PrEP eligible individuals and individuals that are not virally suppressed. So those are kind of super categories across all of the plans. And of course, we are looking forward to sharing best practices, including our distinguished panel today. So I can entertain a few questions or any clarifications, and I'm certainly available to answer questions via email. If you want to provide more input to the plans as they're constructed, we're certainly, I'm certain that the counties would be very happy to get your feedback as well. Thank you.
Wonderful. Well, thank you so much for that great presentation, Leroy. Before we move into a little bit of Q&A, I just wanted to note that, our other two California EHE Phase 1 counties, Los Angeles and San Francisco, are also working on some really wonderful community engagement efforts as part of their EHE plans. They shared a little bit about that at our last Learning Collaborative session. So San Francisco has several community engagement grantees that they're partnering with to engage communities most impacted by HIV, and Los Angeles, I know, recently launched a new EHE steering committee, and they're working to develop a community mobilization program. So it's just really great to see this key focus on community engagement across all 8 counties. Leroy, we did get just a few questions for you. So I wanted to start with a question that says, what do you see as some of the greatest opportunities for growth in the county community engagement plans? And can you say a little bit more about communities we aren't yet reaching or innovative strategies we still need to explore?
Yeah, I think, well, taking a look at the advantage of working through existing partnerships are that certainly we're able to reach a level of community. It makes sense getting community input, but I think that we still have to reach individuals that are actually not coming to the table at all, not in care, that are not well served sort of across sectors, and that aren't going to be found at the planning table. And so I think working with both planning councils to get more people to be part of that forum, but assisting the counties and really reaching individuals that are at the next level of individuals that we'd like to reach, folks that are truly not at the table, not in care, not in any support group. And we can only reach that intermittently through in layers through communities, and asking communities that have access to these populations as part of the way that they live, and ask them to partner with us to help bring people that are truly not at the table. And one of the difficulties of COVID-19 response is that it makes that work that much more difficult. And so looking to not build like forums where we invite community that are not likely to come already, but instead go to places where community have some intrinsic value in certain places, and we go to their house and we ask them if we can politely actually incorporate some of our questions and the needs of getting input from our interventions in places that are built in online communities already. That I think the process of building a Zoom meeting and inviting people to come to that meeting is we're going to be spinning our wheels and not reaching the people that we really want if we wait to actually build those online forums. Instead, go to those forums that are built already. I think that it answered that question. So, and areas for growth, I think that working more with multi-sector. So I think that we have parts of the plan that include sections about substance abuse, but working with substance abuse providers, behavioral health providers, making a more concerted effort to think really about meth and opiates and how those are impacting the access to the interventions that we have. Certainly in anecdotally and through data across the counties, that those individuals that are polysubstance users are profile as not being in care more than other populations. So it's going to be a critical thing to reach those populations. And also where mental health and substance abuse overlap, reentry populations are another area that I think that we can definitely do some work with, working with providers that have access to prisons and jails, In the plans, there is mentioned across all of the plans actually that it's critical to get to reentry populations, but some of the relationships that are already built by providers to serve those communities as they exit prison and jail settings would be definitely an opportunity for us to help each other further and make sure that these interventions are connected to the communities that need them most.
Wonderful, thank you so much. We just have a couple other questions for you. So one says, I'd like to know more about mobile units in collaboration with brick and mortar. Are there prerequisites that need to be met to qualify? What kind of clinic or brick and mortar organization are you looking for those opportunities?
Right, so that's an excellent question. And one of the things that I think is going to be part of this, the formative work in the next 3 to 4 months with the counties are looking at how to build out both the protocols and everything that's necessary to create a mobile clinic, but also to find partnerships to create something like an outstation clinic somewhere that would be a home base in certain areas. I'm just going to throw out West and South County of Riverside would be looking for areas where there could be a home base in a building. You know, thinking about how mobile clinics operate, usually mobile clinics can operate under the umbrella of a home clinic. So if you have like a licensed clinical site that has a lab, et cetera, that those protocols can be extended into remote services as well, but there's a protocol and a process to do that. I think our next steps in building out these interventions is really looking to bring in experts on mobile clinics, and we're looking to build out some type of technical assistance for the mobile services across the counties. So it's definitely worth having a conversation just on mobile services and how to do those well, but that's a great question.
Wonderful. Well, thank you so much, Leroy. We do have a few other questions coming in, and we'll make sure to get those answered in the Q&A box. But I just want to make sure that we have enough time for our panels. Now we'll move into our next section. I'll pass the mic over to Commander Michelle Sandoval Rosario and Lieutenant Commander Jose Ortiz from the PACE program, who will be facilitating our next section, which is our Community Engagement and Mobilization panel discussion.
Thank you, Elena. Good morning, everyone. So now I would like to introduce our panel, beginning with Dr. Sophie Wong, Director of the East Bay Getting to Zero.
Good morning, everybody. Okay, I will go through my introduction. Thank you. Good morning. My name is Sophie Wong, as Jose introduced me with, and I'm here representing East Bay Getting to Zero. Our vision is to get to zero HIV stigma, zero HIV disparities, and zero HIV transmissions here in the East Bay by advancing health equity and healing. And this photo is of our linkage retention group almost exactly a year ago, pre-pandemic. We got together in person. Imagine that. It looks crazy now looking at this photo, right? And it's just great because we've been in existence for 9 years. Our linkage retention group started about 9 years ago as a ragtag group of frontline volunteers, of CBO and frontline workers who are just like, why are we losing 40% of people in care? And so we got together to try to tackle that question and figure out how to address it together. And it grew. We brought in more community-based organizations, more community advocates, more frontline workers. And you can see here, it's just this amazing group. Like CalPEP is a huge part of that. Reyna's here from CalPEP. You know, it's a great group of people from public health, from schools, from faith-based organizations, from CBOs, people who are in the streets doing the work. And just really, really grateful for everybody coming together. We're now meeting virtually. And this photo was actually taken by Mr. Jesse Brooks, who is now our advisory board chair and has been a longtime HIV community advocate, particularly in the Black community. And so just really grateful to have such wonderful leaders in our community as part of this effort. And if we could go to the next slide, please. This is just an overview of our community engagement efforts for the 5-year strategic plan, which Leroy and his team are also part of. And so we are having 4 live workshops for content development, and now we've done it all virtually. 3 have been in English, and this afternoon we're having our first one completely dedicated in Spanish. So really excited about that. We also have all our draft documents posted publicly online at ebgtz.org, and people can provide feedback anytime via the form or by email. We also plan to have a community town hall event to present the first draft of our kind of sub-plan of the EHE plan on December 4th. And then we'll use that feedback from the community to write the second draft in January. And then again, provide everything online for online feedback, just basically trying to provide as many routes possible for people to provide feedback at any time for, kind of open access. You can see here, I love word clouds on the bottom right-hand side of this slide. This is a word cloud we made answering the question, how do we want to look like post-pandemic? And this just really great, some great additions from community members here about wanting to be stronger, loved, alert, wiser, grateful, and resilient. So just really grateful to be part of that vast community with all of you. Thank you.
Thank you, Dr. Wan. Our next panelist is Mr. David Coleman, Social Support Coordinator for Black AIDS Institute.
Oh, I did it. Okay, great. Hi, everyone. My name is David Coleman. I am the Social Support Coordinator for the Black AIDS Institute. Dr. Sophie Wong, I would really appreciate a screenshot of that word cloud. It was very inspiring and great, and I need it in my life. Thank you for sharing that. I'm really excited to be here. I work at the Black AIDS Institute, which primarily focuses on ending the epidemic in Black communities. From what we know, the government and people don't necessarily care about Black people first. So our organization definitely puts Black people first to make sure that we end this epidemic in our communities. I run 3 programs at the Black AIDS Institute, all under the umbrella of what we call Revolution in Color. These are youth programs for Black queer youth. One of those programs is called the Core Group. It's a group of Black queer men that get together, they talk about their lives, they talk about sex, they talk about what's going on in their relationships, their family, being queer, different things that come up for us every day that may not necessarily come up for someone that is not of our demographic. So we discuss those things, and then that group goes on and puts on other groups for their community, which we are now calling Freak Fridays, F-R-E-Q, Freak Fridays, like frequent Fridays, in which we talk about just everything under the sun, whatever they want to talk about that day. They'll prepare a lesson, and then we'll deliver those messages to the greater Black queer community. And then we have a third program that's just starting up now. It's called our DHP program, Digital Health Program, in which we are teaching our Black queer people how to reach out to other people through digital platforms. So how do we talk about HIV online? How do we pop into that Twitter thread that's really problematic, or not pop into it? How do we handle those issues when it comes to being online? Because as we know with COVID, we're not seeing each other in person. I haven't had an in-person group since February. So how do we still reach out to each other? How do we still support each other? How do we make our lives better in this really, really hard time, on top of dealing with sexuality, HIV, all of these other things? So those are the 3 programs that I run. We are looking to run some more, but right now we're focused on that and continuing to adapt everything in the times of COVID.
Thank you, David. Thank you. Next in line, we have Ms. Reyna Perez, which is Program Manager with CalPEP.
Hi, yes, good morning. My name is Reyna Perez, Program Manager at CalPEP. We've been around since 1984, dedicated to providing coordinated HIV prevention and care, specialized outreach and navigation services for communities of color throughout the Bay Area. We provide services to all, but most importantly, we focus on providing services to people experiencing homelessness, people who use substances, sex workers, previously incarcerated individuals, and people of trans experience. We do this by providing rapid mobile HIV and HCV testing. We have a medical transportation van for all clients living with HIV/AIDS, retention navigation services for getting people and retaining them into medical care, and substance use and mental health services as well on site. And some of our programs that we currently have that are focused on HIV care and prevention include our case management model, which is where we assist clients into staying retained in medical care, as well as linking newly diagnosed clients into medical care. And we primarily do that by using a peer model approach and making sure that we're able to link these community members with other people that are also have experienced the same thing in the past. And we also have currently our mobile one-stop services team, also called MOST, which is a community collaboration focused on bringing essential services to unhoused communities in Alameda County. And while our agency provides like brief case management and HIV testing, we also partner with a lot of other agencies in Alameda County to make sure we can provide like basic essential services from food, needle exchange, and other services that the community is demanding. Thank you.
Thank you, Reyna. Thank you. Now we have Dr. Tony Dorsey, Director of Transgender Services at Borrego Health.
Well, good morning, everyone. As I was just introduced, I'm Dr. Tony. I am the Director of Trans Services. And yesterday, the reason we don't have a pretty little slideshow for me is yesterday we opened up the first dedicated transgender clinic in both Riverside and San Bernardino counties. So I've been really busy the last couple of weeks. For our focus, of course, obviously, if I'm Director of Transgender Services, I'm going to be dealing heavily with the transgender population. This is a major focus. I also am on the Inland Empire HIV Planning Council with some of our people. I'm going to give a shout out to Benita there. And one of the keys that we've noticed is that trans positive folks are highly underreported and are not effectively being reached. So we can't even begin to identify some of the challenges in EHE that we have to address with them. On our part within Borrego Health, we're ramping up an immense opt-out program. We're opt-out only program for testing as a whole. We're for getting testing and getting on PrEP. We're trying to do that. We talk about PrEP fairly consistently. We have new PrEP navigators, and we have mental health folks that are actually focused heavily on HIV survivors. I also work with the Task Force on HIV and Aging that's local here. PS HARP, I think is what it's called. And we do a lot of work there across the thing. And my primary focus on a lot of this stuff is that we want to make sure that people who are addressing the needs of trans people remember that trans people have to be addressed as trans people. That's a really essential category. I have to say, I love the fact that somebody mentioned trans people specifically, finally, because nobody else did. And that kind of gives you an idea. It's not that we're trying to forget that trans people are part of this, but because we're focused on the larger group, we forget that these smaller groups, Two-Spirit, trans, just even veterans alone, ex-offender reentries. You know, we need to find out what these smaller groups and these groups that combine multiple intersections can use in order to be able to identify better strategies and better solutions. One of the things that's important about this, having a clinic that's dedicated to trans stuff, is tying back into another thing. Now we could actually begin the process of setting up a mobile trans clinic that can go out to a lot of the rural areas. Apple Valley has a huge transgender population, and nobody knows how many HIV positive folks there are. So for me, from my perspective, a lot of what we're trying to do is gather the information while also working on prevention, and the whole thing comes down to EHE. So hopefully this is going on and we're doing a good job, and I'm glad to be here. So thank you for having me.
Thank you, Tony. And lastly, we have Ms. Karla Torres, Associate Director of HIV Services at San Isidro Health.
Good morning, everyone. Thank you for the invitation. I'm not sure if the slides are going to be showing. Oh, there we go. My name is Karla Torres. I am the Director of HIV and LGBTQIA+ services at San Isidro Health, and I'll be going over our services of HIV care at the US-Mexico border. Next, please. So San Ysidro Health was established in 1969 in the San Ysidro, U.S.-Mexico border community by 7 founding mothers, activist healthcare heroes. Come 51 years later, now we're a large federally qualified health center serving over 100,000 patients in multiple regions throughout San Diego County. Our community is very diverse, historically underserved, with high rates of poverty, uninsured, and non-English speaking household. Majority of our patients, 71% are Latinx, 7% Asian Pacific Islander, 5% African American Black, 17% White Caucasian. And as you can see, 89% of our patient population fall under the 200% federal poverty level, and 24% are uninsured. With our mission is to improve the health and well-being of our communities we serve with access for all. Next, please. Our HIV program started very similar to the rest of the organization. Back in 1990, we started as a social services agency known as South Bay AIDS Project. It wasn't until 1999 that we opened our first HIV clinic in the South Bay, with only offering services 4 hours a week. 2001 to the present, we're now fully expanding our clinic services to 2 full-time Ryan White clinic sites. Our HIV department is currently at about 50 staff members per year, with multiple programs offered throughout the entire county of San Diego. We are one of the largest HIV programs in San Diego County and the only HIV specialty program in South Bay. And as you can see with our mission statement for the HIV department, we continue to provide culturally sensitive medical, social, and support services free of charge that enhance the health and enrich the quality of life for people living with HIV and their families. Next, please. So what do we look like as an HIV program? We serve over 1,300 patients, clients. We use that term for both sites. We have 3 HIV clinical locations integrated with primary care, HIV specialty care, transgender care, health education, treatment adherence, routine HIV testing, and HIV prevention services. Our model of care includes rapid ART, which is the standard of care, and PrEP services are all co-located within our facilities. We do have 2 HIV services sites that offer case management, mental health services, insurance enrollment, peer advocacy, various support groups, food and housing assistance, referrals for transportation, legal services, substance use and addiction counseling, and many other resources available. We do extensive amount of community outreach and testing and linkage to care. Our linkage to care has been one of the highest in the San Diego County, with 92% of our patients being linked within 30 days of diagnosis. We are focusing in the last 2 years of doing rapid linkage to care so that clients can come in and once they test preliminary positive to be linked within 24 to 48 hours. We also offer PrEP and PEP and various social support services. And this year and a half, we've expanded our services and research. So we want to make sure that our information is educating the medical community, that we are getting community engagement and advocacy. And you can see our sites here, our GEMS Health Clinic focusing on transgender healthcare and primary care for the LGBTQ community. Thank you.
Thank you, Karla. Thank you, Karla. Thank you to all our panelists. And now I would like to invite to this conversation Dr. Sandoval Rosario from the PACE Program Region 9 to facilitate our QA section. Thank you, everyone.
Great. Thanks so much, Jose. And thank you all so much. And I truly want to say it is an honor to be in a room. I'm going to say in a room, we're all virtually together with all of you. Really, you are the boots on ground, the ones working directly with those communities who are most impacted by HIV. So thank you so much for your work. And now I'd like to get to the exciting part. You know, you talked a little bit about some of the things you're doing in your organizations. And now we just have some converse. I'd like to have a conversation with you all and really learn, you know, what are some unique things you're doing in your organization and community, specifically with the populations that you discussed that you have prioritized and served. And the first question I have for all of you is really, what are some strategies that, or initiatives or tools that your program or your organization is doing to reach those communities that you prioritize. Dr. Tony, you've talked a lot about your focus around with the trans two-spirit community, and Reyna, you talked about your work with the homeless. What are some things that you're doing uniquely in each of your communities that could help us as we end the HIV epidemic? And whoever to go first.
Of course, I think one of the main things, especially working with people that are currently unhoused or unstably unhoused, is going to the community members. So it's not about waiting for these community members to find a way into our office, but really providing mobile services for people that are experiencing homelessness. And that includes, we have 2 RV mobile units that we use as like a rapid HIV testing clinics. And now we're doing that a little bit differently because of COVID, and we're doing that outside in canopies, but also really providing these services in a collaborative community way, which means partnering with other agencies, like I was saying, to provide other basic services, like people, something I just wanted to kind of bring up. In 2019, we had a pilot for this program, and we found that 79% of the people we surveyed required shower services, 78% of people requested underwear and socks, 44% of people needed access to food, and 58% of people requested access like mental health and substance use services. And we use that kind of information to be able to kind of provide a collaborative community of agencies that could provide some of these services, including like we partner with HEPAC for providing needle exchange services. We partner with Allen Temple to provide hot meals and like grocery bags as well for people that are needing that service, as well as World to provide navigation to other social services so people feel more connected and are able to access those services while also accessing, rapid HIV testing and linkage to care.
That's great. Thank you so much. I see Dr. Tony, you're unmuting, so I'll hand it over to you.
So in my particular case, one of the things that we do is we have 3 trans navigators who are members of the community. With the new clinic, we also have a CSR who's also a member of the community. And the goal that we have for all of them as part of their overall thing is to be involved in the community, whether they're entertaining, whether they're talking to people, whether they're just chatting and using social media and other forms. I mean, the trans community is extraordinarily well linked together, and we can do a lot of different things that a lot of people tend to not realize how well we can communicate. The catch is that bad news travels faster than good news. So you could say one bad thing and it'll go like lightning throughout the whole thing, and now all of a sudden you've burned off a couple of little limbs. And so we're doing a lot of work around making sure that all of those limbs are regrown and then reattached and whatever, because being able to utilize our social networks effectively is one of the keys that we've discovered to ensuring this. We grew from under 200 trans patients to over 1,100 in 2 years. So that, I mean, we're really relying on the community itself to help itself. And it's useful because, we have resources and we can find additional resources and we can do incredible things. But that's the trick, is being able to make those connections within the trans community. It really does come down to who you know. And we want to be sure that we achieve those goals where they live. That is always the first thing. You have to get to people where they live, not just in a physical sense, but in an emotional sense and in an intellectual sense. So you have to be able to cross all of the different little demographic barriers that we create for ourselves in order to reach in and say, hey, I need you to just come here for 1 second so that we can make sure that you're healthy, that we can make sure that you're getting the care that you need, and that you understand we're always going to be willing to listen to you. Even if we happen to disagree with you about these things, we're still very much here for you, no matter what it is. And that becomes a really essential category in terms of what we're trying to achieve and how we're trying to achieve it. A good example of that is we do have 2 support groups. We have a rather structured support group that happens on Fridays, and then we have an unstructured support group on Mondays. This Friday, we're going to be holding a Transgender Day of Remembrance out in front of the clinic. It's not because we're trying to say, oh, we want to take away from anybody else. It's not everybody can go to the same place. Not everybody can get there. And as we go forward, we'll do our best to continue highlighting these elements. The last part is making sure that we always utilize the role of lift others up. The first and most important function is, if you find somebody in your community who's worth helping and who's worth being something, lift them up. If everybody's lifting somebody up to help them move forward in any way, then you're going to achieve it. And that's what we put a lot of work in on our part, within my department at least. And then I know it as a whole, both the HIV Planning Council for the Inland Empire and Borrego Health are doing that, as well as all of the other HIV providers in our region.
That's great. Thank you so much. David, did you want to share some of the work that you're all doing with the youth
Sure.
organization?
Yeah. I was struggling with the word unique because I'm like, are we unique for doing this thing? I think a lot of people do this, but just simply just meeting people where they're at. Dr. Tony kind of spoke to this as well. We started off our digital groups on GoToMeeting. And we're working with youth, right? I don't know if any of you have heard of GoToMeeting. Most people have not. It was more so a platform, a platform for nonprofit people and like professionals. And we were trying to do youth groups in GoToMeeting. Why? For what? Download a Zoom account. What are the kids using? What are they engaging with? That's what we need to engage with. Outside of that, we are now working with a new platform called Bigo. I don't know if any of you have heard of Bigo. It's all the kids are talking about it. They're on it. They're doing presentations and they're doing seminars, and they're just really using that platform to really get their voice out. And so now we're transitioning over to using that as well, because that's where they're at. Right now, people are on Instagram, Twitter, Bigo, all these other platforms. And when they switch over, we have to move with them. We're not going to ask them to come to us. We are going to go to them. We're going to meet them where they're at, where they're most comfortable, because that's how we get, that's how we all learn. That's how we all grow, and services get done. So yeah, I don't know if that's unique, but that's always my philosophy, is just meet people where they're at, no matter what situation, no matter who they are.
Thank you. Thank you for sharing that. Karla, you mentioned the work that your clinic is doing on the southern border. Maybe share a little bit about some strategies you're doing to meet where they're at in that region.
Absolutely, thank you. So prior to COVID, everyone was doing outreach, field work, and trying to find individuals, get them into services. Now with COVID, all of that has shifted, and yes, a lot of us are turning to telehealth, phone. A lot of our patients don't have access to that equipment, so our efforts have been more actually phone calls, and they appreciate getting the call from their doctor and getting the call from their nurse and their case manager. We continue to do social media postings. We have weekly check-ins, and just any topic, we're updating them on our operations, how things are shifting in our clinics. Where can they go get tested for COVID? Where can they go get tested for HIV, and resources available? It's a lot of work that we have to do with our partners across the border. You cannot end the HIV epidemic unless you target both sides of the border. That's just how it's going to work. So we do partner up with our partners. We have a collaborative, binational collaborative with partners across the border, and we talk to them, what are the struggles that they're seeing across the border? Patients who cannot cross, how do we communicate? Facebook, Messenger are our ways of communicating with clients on both sides of the border, and they appreciate the live streams. They appreciate the presentations that are being brought, the resources that are being shared. Answering Messenger in the middle of the night when they're asking about, hey, did you think I put myself at risk if I didn't use a condom or the condom broke? So having these types of availability, like you mentioned, David, meeting them where they're at when they need it, not when you feel that you can answer that message. For them, it's urgent and we want to reply to them immediately. We're very much aware of what's happening with the Ready Set Prep, with Prep app, and making sure that everyone in our team and the rest of the organization are familiar with access to PrEP, with access to PEP, and know that we have a very strong partnership with agencies in the entire county of San Diego. So we work very closely with San Diego HIV, STD, and hepatitis branch, with our partners in other community clinics throughout the county. And what are they offering that we can leverage, that we can share with our clients? We have this very friendly approach in San Diego County, not a competitive approach, that if we have a resource that's available, we open it up to everyone. If another agency in Vista or in Central San Diego Family Health, UCSD has a resource for our clients, we know about it and we refer. We want to make sure that we bring those informations to our clients. Other things that we've done is bringing back HIV testing to the medical setting, but now the dental. So routine HIV testing in the dental setting is a new strategy we started to implement prior to COVID. COVID kicked in, dental settings closed across the entire nation. We just started retraining our dental providers, and we go live next week, which we're really excited about. We tried it out a couple of times before COVID, and it worked well. So engaging with everyone is really important through any means, social media, phone, in person when you have the right precautions taking place. And obviously your partnerships with agencies, both sides of the border, is crucial.
Great, great. Thank you so much. And Dr. Wong, if you wanted to share, you shared a little bit in your introduction, really the multi-stakeholder and partnerships that you're working with to engage with just different communities to be able to get feedback. Do you want to share really how you've been doing that through Getting to Zero?
Sure. Yeah, it's just great hearing how you all are figuring out how to switch services and engage people in this extremely challenging time. And David, I'm going to check out Bigo. Thank you. We're not a direct service provider, so we kind of face special challenges around that. When I work in a clinic, I see all sorts of people coming through, right? And so I can engage people one-on-one and all that kind of stuff. And I'm also working with the street teams and folks like like Reyna and the CalPEP teams who are actually in the streets doing the work, right? And so I'm kind of one step removed in that way because we're not a direct service provider as East Bay Getting to Zero. And so what we need to do is make sure that we have representation from the people who are connected to people in the community, and also representation from those communities too. So it's kind of like both, it's like several layers, right, of people. And then also making sure that we have community advocates who are not necessarily, medical providers or healthcare providers, who are not public health staff, who are at the table making decisions with us. And so just being really intentional about having community members who are people living with HIV, people who are using PrEP, who are part of our decision-making processes. So making high-level decisions on our advisory board, on our steering committee, that's really important to us. And Yamini Asagwara Bhatnagar is our program manager and has been doing an amazing job just like reaching people however possible, calling folks, texting folks, like just really doing a lot of one-on-one outreach and listening and hearing where people are at, what the needs are, and just being really flexible on how we engage folks, which I really appreciate because, I've been kind of stuck in this like health professional setting for so long and the public health setting. So I need that, expansion of brains and expansion of methods of reaching people. So I just really lean on all of our community advocates who are in the streets, who are doing the work that you all are doing to link us to the people on the ground and the needs that arise, so that we can advocate on that kind of meta level for the strategy and for the funding and for the services to be coordinated on that kind of meta level.
No, that's great. Thank you so much. And we did receive one question from the audience, and I'm going to read it and see who would like to answer it, because I think all of you work with some of these communities. The individual said, I'd like to know more about community engagement strategies among African-born populations. These populations are hard to reach and are affected disproportionately by HIV and AIDS. Any information? So the work that you're all doing, any outreach efforts you're doing around specifically with African-born populations. I'm sorry, David, I think you were going to unmute yourself.
Yeah, this is a really great question. And to be honest, I have not figured this out yet. The closest that we're getting to reaching African-born populations is kind of word of mouth. We have some African-born people in our youth groups, and they'll tell a friend, but we have not directly reached out to them. We have not necessarily planned to reach out to that community, and that's a fault of ours. So that's something that is absolutely necessary. These communities are disproportionately affected, and in the future, we're gonna work towards trying to reach out to them in definitely a better way. But right now, it's pretty much word of mouth.
That's great. Any other thoughts from any of our panelists on the work with African-born communities?
I agree with David. It's definitely word of mouth what works better, and working with them from the moment that we schedule the appointment. If there's anything that we can do to make the visit better for them when they come in, if they prefer an interpreter, if they prefer a female versus a male or a male provider, frontline staff, and just trying to, make them feel that we want to make sure that we're there for them, and they get to spread the word. But it's really hard to post anything on social media. We don't see a lot of interaction in social media. We don't see a lot of opportunities for outreach. When we do outreach in the streets, they're not comfortable being approached. They're not comfortable seeing our mobile units. So it's a matter of the resources are there, give us a call, and we'll try to come back. Maybe as more that they see the mobile units, that they see our faces, they become more comfortable with our services. But a lot of it's just getting that word out that we are here to serve them.
No, that's great. And I think that leads us on to our next question for all of you. In thinking about the things that you all are doing, what are some lessons that you've learned along the way as far as what works and what doesn't work in an effort to engage with the communities you serve to end the HIV epidemic? So really, share with us, what are some things that we should be aware of when we're trying to meet the trans community, MSM, Black queer community, the Southern border? What are some things you would recommend?
I would say, oh, I'm sorry, Dr. Tony, go ahead.
No, go for it. Go for it.
Thank you. I would say letting, as far as the Black queer men, Black queer community, I would say give them the power, give them the decision making. If you have a space, and right now we don't, we're not meeting in spaces, but if you have a space that's theirs to decorate, that's theirs to control, it's for you. A lot of Black queer youth don't feel like they have anything. So if you give them the opportunity to have something, to take care of something, to love something, to really grow with something, then it just works better for everybody, right? Now they trust you, rightfully so. Now we're talking about medications. Now we're talking about testing. Now we're talking about STI treatment. Now we're having these conversations because you gave them something that they own and they feel a part of, and they're ready to work with you. So I would say definitely just give them something to own, something that they can have.
Okay, what I was going to point out is one of the things that we discovered doesn't work is an absence of cultural competency that goes beyond simply the most basic stuff. And I'm going to use the trans community as an example, something that I'm taking my little quick notes here on my little sketch pad here. Something that I like to point out to a lot of people is that we have a pregnant gay Black man. And how do you address the needs of a pregnant person without trying to figure out how to say this, without putting yourself in a situation where now you're screwing up in race, you're screwing up in gender, you're screwing up in social class, you're screwing up with everything because this person did not know that they were pregnant. So that became a challenge for us that we had to overcome. And that's one of the nice things, is that the reason we were able to identify that is because we've made sure that we're absolutely cultural competent. We'd actually discussed with several providers, hey, we're going to send guys to you, and every now and then that guy might need a pregnancy test, especially the gay ones, because a lot of people don't think about the fact that there are gay Black trans men out there. It doesn't occur to them. The CDC only recognized trans men last year as part of the research. It's the first time that there's ever been any kind of thing come out that speaks to the challenges of gay trans men in specific. So by focusing on these groups that everybody tends to forget, we've had a lot of success in preparing things. An example is, I don't allow anybody to use the words female or male around me. It's always man or woman, because we're dealing with gender, not sex. I always use the terms masculine and feminine as opposed to trying to do it, because even non-binary people are sometimes on the masculine scale, sometimes they're on the feminine scale, sometimes they're neither. But by using feminine and masculine, now all of a sudden we're not saying, oh, that's a trans female or a trans woman. That's a person on the trans feminine spectrum. And it allows us to start identifying things much more culturally competently and to think in ways that change just the core centers of how we approach our work. I will point out that I'm not medical. There's some psychology in my background and I had a practice and all that. My actual field is sociology. So I approach all of this from a sociological standpoint. And that means I'm looking at the systems and I'm looking at the structures, and I'm really getting into some good roots and figuring out what is the issue that runs from this and how do I track these things down. And that's been how we've achieved most of our successes and how we've identified all of our failures.
Great, thank you. Dr. Wong, did you want to add to really, I think what you're doing is really unique. What are some lessons learned or things that you've tried in engaging the community to provide feedback that perhaps didn't work, and what did you do differently? Any recommendations, especially for counties who are trying to really engage with the community to include in their EHE plans?
Yeah, it's a great question. And it's definitely something I stumbled through over the last decade or so. Again, you know, coming from a medical perspective, training and all that stuff, I don't speak the same language that a lot of folks speak, right? So I think that's really important for me to recognize that the language that I use, the formats that I use don't work for a lot of folks. And so I need to really lean on this extended network of people who are communicating in all sorts of different ways that I'm not necessarily good at or skilled at, and who speak lots of different languages. California is super diverse. There's a ton of languages. It's beautiful in that way. And it's also a beautiful challenge. So, you know, when talking about engaging the African and born community, that's a particular challenge for us. You know, we have a large Amharic speaking community here in Oakland. And so thinking about how we engage those folks and you know, just think it's a special challenge that I think can only be solved in a collaborative format. And so I just lean really heavily on our amazing networks of partners and really trusting them to do what they have been doing for, you know, like Reyna at CalPEP, right? Like CalPEP's been doing this work in the streets for decades, right? So they know how to reach folks in these particular communities that I don't know. So I really lean on that. And I think that's something that I've learned is just really like being able to lean on folks and asking for help a lot. Asking for help. And I know it ends up being, you know, a lot for folks, but just like providing that container, right? We can give you the container, the structure. We can pull your input into something that then becomes the strategic plan that then informs funding, you know, so just trying to basically give that power to folks to provide that input and to participate in that way. So I think the bottom line here is like no door is a wrong door. So whatever door or footpath or dirt path or whatever it is that you're on, you know, there's no wrong door to access us and to provide feedback and provide input. And I think we still have a lot of work to do with that, but that is the basic premise of it. And we're hoping to just like grow that out.
Thank you so much. And Reyna, since Dr. Wong mentioned the amazing work y'all doing, what about with you know, your engagement with those that have unstable housing? What have been some challenges? Because I know that has been a priority for many of our jurisdictions around their EHE. What recommendations do you have as far as those challenges?
Of course, I think one of the biggest lessons we've learned as an agency across like the 3 decades we've been around is definitely in not assuming that we know what the community needs and really engaging with the community and talking and kind of figuring out what do you need. And so that goes hand in hand, I think, all across all the work we do here at CalPEP. But I just kind of like to point out like how, for example, if we're testing out in a community, say we parked our mobile next to an encampment, we're offering testing at unique hours where the community members are available, whether that be like 1 a.m. or 5 a.m, right? And so say we parked our mobile unit there and we're providing testing. Say I'm the test counselor and give the preliminary positive result. Before they leave our RV or now our canopy, since we're doing this outdoors, we make sure that we have a clinic that this person is able to go to for their confirmatory test the next day. We make sure that they're able to, have any barriers removed. Okay, they don't have transportation. Let's connect you to our medical transportation services in that moment to make sure we have a way to get you there. You're hungry. Okay, let's make sure that you can either have some food from our food pantry or connect you to a food pantry that's readily available closer to you. And removing these barriers little by little in that first interaction. And then by the time their first appointment comes around, the same person that either tested them or one of our case managers that has already been connected with them would be the same person that meets them there at their appointment to start removing some of that medical mistrust that, has built up over years of a person's lifetime. And that same person that, gets introduced to their primary care doctor and goes to their first appointment is a person that, continues to have that conversation with them across the time that they're our client, whether it's like, there's a new barrier within social services, there's a new barrier within this or that, and we need to find you housing, we need something more urgent. That same person, is a person that kind of follows that client and they get connected to a peer with a similar life lived experiences to make sure that that person feels kind of connected to a community of resources through our agency and through any referrals that we make. And, these warm handoffs and kind of ways of meeting clients where they are and meeting them at their appointments, it really helps kind of remove some of those layers of medical mistrust that are one of the biggest, in my opinion, one of the biggest things that we found is difficult to kind of link clients into care. Mm-hmm.
Thank you so much, Reyna. And Karla, I do want to give you an opportunity, but Reyna, you touched on a question that we did receive from the audience around how community engagement helps to address medical mistrust and what that really looks like. And you talked about, forming that relationship first. So thank you. But I wanted to see if anyone else on our panelists had some thoughts around that.
Oh, hello?
We hear you.
Yeah. Just a quick thought around that is, as far as medical mistrust, definitely happening in Black communities and queer communities. I think for me, what is working now is really digging into the history of it, letting clients know that they're not wrong. Like, we get why you don't trust the government. We understand why you don't trust doctors. This has happened. This has happened. This has happened. And truly going through that history and accepting it. Like, this did happen. Now we're going to move on to these facts. This also is happening. This is happening. This is proven. This is proven. So if we just give them the truth and stop trying to sugarcoat it all the time, oh, trust your doctor. No, don't just trust your doctor. Your doctor may not be trustable, but here's how we can find one that is. Acknowledging, accepting, giving the truth, facts, and then moving on from there.
Yeah. If I may add to that too, it's communicating to all of our partners too that clients do have a mistrust. So you're not going to expect the client to link and follow through their housing plan or their care plan unless they trust you. And building that trust from the case manager to the doctor to the receptionist takes time. And they want to see that you really are working with them, for them, and that you're going to get them the care that they need. Until you get to that level of trust, they're not going to engage. So for me, a lot of work has been done more on the advocacy level. I'll talk to case managers. What are you seeing? Why is the client not following their care plan? Why are they still unstably housed? Well, they moved in from another part of the country. They moved in from another part of the world. And it's going to take more effort on everyone's end to build that trust, to explain to them that we're here to help them, that we can have a good relationship and getting access to housing and food and medical care. But in that meantime, I have a very short amount of time to work on that trust pattern. So a lot of it has to do with advocacy and getting everyone on the same page.
I'm going to go ahead and state that I absolutely agree with that, because one of the things that we tend to try and do a lot of time when we're looking at large scale issues is we try and say, well, it's a one size fits all effort. And the strategies that I've used that have worked with refugees do not work when it comes to trying to deal with another population, such as ex-offender reentry. But one thing that I can say has been really, really effective is to make sure that all of our approaches are trauma and abuse informed, and that they focus on the social determinants of health in addition to simple health. Among the things that we've done, and I just to give you a couple ideas, we do check-in calls with patients that we know are in more challenged situations. We prefer video over phone when it comes to a telehealth appointment. A lot of people are like, I'd rather just do it on the phone. And we're like, no, we really don't want to do phone. We want to do video. And the reason we want to do the video is so we can see, their roof and make sure there's no, cobwebs or whatever. Make sure that if they're at a much lower point of origin, we can see that their living conditions are decent, and that we can look at them and see how they're doing. What's their energy level? What are their other things? And then on top of all of that is the thing that everybody kind of thinks of in doing just in chunks. And that's an ongoing, constant, rolling needs assessment. Because it can change quick, or you may suddenly get a sudden boost from this population that's right here that have these things in common that you would never have noticed if you were to do those needs assessments once a year or once every 2 years, as we see a lot of the case, especially for these smaller populations. And I think that those have the biggest impact in terms of letting people understand that, yeah, we've been there. And then, of course, it's the trans community. We've had the medical establishment essentially attacking us since 1852. So for us, trusting medicine when we absolutely need to has always been a back and forth and a give and take. And the fact that all of us are members of that community, that they see, that really makes an immense difference, because we know it. And we train each other on some of the history of what we've done and how we've accomplished it and what's going on. Most people couldn't even tell you what WPATH is. Most people couldn't tell you what the standards of care are. And yet my team has them printed out and ready to go with people. I mean, we want to educate and inform as we go.
Thank you so much. That's great. It's excellent to hear. And then we received another question around youth. So when connecting with youth or young adults, communities to other HIV resources, what are some best approaches that has worked for all of you? And David, maybe I'll start with you, because I think that's one of your focus area in reaching young MSM communities.
Yeah, so the question is how to reach youth.
Yeah, it says what has worked to connecting youth to HIV resources.
Okay. I apologize for continuing to say the same thing, but I think it's that meeting people where they're at thing again. Bring your services to them rather than call them over to you. Simply put.
Well, that's great. And I think as much as we can repeat it, there's no apology. So definitely. And Karla, I wanted to give you an opportunity before we move on to the final question around COVID. What are some lessons learned that you all have learned along the way that you could recommend for those who are working with Latinx community around HIV prevention and diagnosis and testing?
I think prior to COVID, our HIV testing in the field was very successful, and that obviously had shifted. We needed to be quick about what other services can we offer. San Diego County, especially in South Bay, has a very high HIV positivity rate. So we knew if we were not going to be testing in the streets, then HIV was going to increase. HIV rates were going to increase when we did get back to the field. So we started offering at-home HIV testing. Our staff, our counselors would go and drop off a test kit to the client. We schedule a call afterwards, walk them through the process. One of the big lessons learned was that we needed to do a walk through video shared in YouTube on how to do the test. How do you perform it? What are the test results? How do you connect with the case manager? How do you connect with our bridge worker to make sure that you get engaged in care if you are showing a preliminary positive, or if you need access to PrEP? So all of that was put into 2 videos, one in Spanish, one in English, and it has been shared extensively in our social media. That we hope that the at-home HIV testing program can continue past COVID. So now we're looking at what's going to change when COVID is done. I think this is one of the areas that we want to continue telehealth teledentistry, at-home HIV testing opportunities, how to expand that. Our positivity rate has been very high, normally averaging between 3%, which is higher than other areas. With at-home HIV testing, we're at 15% positivity rate. And linkage to care, we are about 95% of our clients who test positive are being linked to care within the first week of getting their confirmed results. That's one of the things that we want to continue. For the youth, what has worked for us and we want to continue, our CHIP program, Comprehensive High Impact Prevention Program, has focused on creating special events, not just targeting HIV or PrEP. These are events for people to create a hangout spot, movie nights, day at the beach, day at the fairgrounds. How do you bring them together so that it's not just drilling their minds about prevention and PrEP and HIV and STIs, but creating a safe network of peers that support each other and encourage each other and build themselves up has been very successful. We've had quite a few participants that are serving as peers, that are bringing back and sharing the word of mouth of how good the program is. So that's one of the things that has worked with youth.
Thanks so much, Karla. I appreciate that. And you answered our third and final question around COVID. And I'd like to hear from the other panelists really how your organization or program has adapted their community engagement mobilization strategies during this COVID time. And I think COVID is here to stay for a while. So I think it's very important that we're able to pick up some of those best practices. So maybe Reyna, I'll start with you because a lot of the work that you all do is really being out in the community, right? Meeting individuals where they're at. What are some things that you all done differently that has worked during COVID?
Definitely. I'm very proud to say that throughout the pandemic, we haven't actually stopped any of our services. We've just altered the ways that we've done them and conducted them, right? So for example, we have a very robust drop-in center that we were using in the past to have clients have a safe space to come into for particular populations, whether that be people of trans experience, men who have sex with men, youth. And now a lot of those have moved virtually into kind of like different Zoom groups and have smaller groups at different hours that people are able to attend as well. And with our work in the field, working with people living with HIV, we started going out again about June, July, and we altered the way we'd provide HIV testing by providing it in an outdoor canopy with 4 walls to increase privacy, as well as having plexiglass dividers, health checks and screenings, and all other services to make sure we can do it in the safest way possible. However, because COVID is something that goes hand in hand with a lot of the things that we're talking about, we also have hired COVID outreach specialists that carry tablets with them. So anytime that we're doing HIV testing, there's somebody available to direct any community member to COVID testing and linkage into other COVID services, whether that be someone needs, a place for isolation, and they have all the resources that are able to link people immediately into some of the things that might not, that I might not know immediately where to link someone into, like isolation care. Our specialists that are doing the outreach would. But yeah, I'm very proud to say that none of our services stopped throughout this entire time.
That's great. So really being able to address the syndemics, the COVID and HIV. Thank you. And then David, you shared already kind of the virtual platform that you guys are in, but our transfer to, for lack of better words. Anything else you wanted to add on as far as what you're doing differently with COVID?
No, it's pretty much that, moving to the platforms that the kids are using, as well as we are able to meet more frequently now. People don't have to leave their homes. People shouldn't be leaving their homes. So we're able to meet 2 or 3 times a week, even if we want, rather than the one that we used to meet. And I'm able to do more one-on-ones with them, more check-ins, more just how are you doing this week? What can I help you with? People have really responded well to that because there's so much less interaction. So yeah, just upping your digital programming because we're all sitting at home anyway. So why not do that? Oh, and I'm sure just as a lot of you are also doing, a lot of my coworkers are working on at-home testing programming, where we're like literally walking people through the test to make sure that they get tested. We'll still be able to provide an incentive and all those great things. So not stopping.
That's great, great. And Dr. Wong, I know that you all, and I know I've participated in some of those sessions that you have virtually. Anything else you wanted to add around what's worked, what maybe you're doing a little differently during COVID to engage?
Sure. So in addition to moving to an online space for our East Bay Getting to Zero activities, we're also supporting our frontline teams to do kind of what you're talking about, the syndemics, right? The cross integration of COVID testing while you're doing HIV testing, and when you're doing HIV outreach to provide information on COVID prevention and where you can get COVID related services or isolation housing, all that kind of stuff. We're just trying to cross train everybody so that we can do outreach on all the things that people need, right? It's like no door is the wrong door and every door leads to all doors, right? So we're trying to really, it's a lot of information and a lot of resources, but as much as we can cross train folks, then we can meet people as whole people and meet all the needs that, eventually meet the needs that they all, that rise to the surface. And I think one of the things that has been really great is that we still been able to work with our community partners to figure out how to do safe outreach. So, basically providing bags of swag that include condoms and lube and masks, things like that. And like little cards about testing, HIV testing and COVID testing, right? So trying to just like put it all together so that people know that we're trying to meet the moment and meet people's needs.
That's great. Thank you so much. And then Dr. Tony, before I pass it over to Elena, I wanted to know if you wanted to add anything more around what you're doing to continue to serve the trans community during COVID.
So I'll be blunt, the one thing that we had to adapt to quickest was the not having physical presence, which has actually increased the level of anxiety and depression within the transgender community as a whole. So we've done a lot of stuff to help kind of counteract that. That's hence the check-ins and the video and so forth. Our biggest thing was because we're a smaller group within a larger thing, it didn't change our resources. It just changed the way that we reacted. So we were able to really spin on a dime to make that happen and be able to address these needs. We're still adding 5 to 10 new patients a week. And we're the only provider in the Inland Empire that does trans youth, period. So when it comes to youth, for us, we're like, oh, well, then here we go. But when you're dealing with trans youth, now you also have trans youth parents. And so we're having to do a lot of education for families and groups and making sure that not only are we reaching out to them on PrEP and PEP, which of course, when you're dealing with parents can be a little challenging at times. And then of course, when you're dealing with, you have to deal with COVID and how can you deal with COVID in your own home? So a lot of our education is going on there and helping to address some of those needs, especially given the structures for meds. The other thing that we've done is a lot of our patients are on meds, and to the extent that we're able in our small little area, we're able to do a lot of delivery. We're able to mail prescriptions out to people, which has been a lifesaver for many of them. And we're constantly looking at new ways to find how can we get what you need to you itself.
That's great. Thank you so much. Thank you all so much for sharing your wealth of knowledge and what you're doing. And now I'd like to pass it over to Elena. I wish we had more time for discussion. So Elena, I'll hand it over to you. Thank you.
Wonderful. Well, thank you so much, Michelle, for facilitating the discussion. And again, thank you to our amazing panelists for all of your wonderful work and insight. We do have a few more minutes, and I just want to maybe share a few of the questions we've gotten in the chat with you all, and then we'll follow up on any that we're not able to get to during the discussion today. So one question we received was asking about a little bit more about strategies or interventions that folks are using for justice-involved people, both inside and outside correctional settings. So they mentioned, as several panelists said, this group of people is underserved and rarely targeted specifically, despite data indicating that they are disproportionately impacted by HIV. Would a social justice lens versus a public health lens be impactful, especially given the current socio-political environment? So I'd love to hear from any of our panelists on that great question.
I can maybe answer that question. So the County of San Diego HIV, STD, and Hepatitis Branch does have an intensive case management program, also known as ICM, which provides assistance to clients who are HIV positive in accessing medical and support services. The program does focus on clients who are currently incarcerated in San Diego County Jail or who require inpatient substance use treatment. And they do offer the case management approach. And when the client might be released, then they work on either helping them connect to care with them or refer the client to another agency where they might be living closer to. That's the program that I'm familiar with. We used to get funded through prevention efforts to do educational presentations in the correctional facilities. That program got defunded a couple of years ago, which is very unfortunate. That helped really build a rapport with the participants. And when they were released or if they had questions, they can always connect or request a health educator to stop by and have a special one-on-one visit with them. And that really helped. It's unfortunate that it wasn't funded again, but right now the only one that I'm aware of is the intensive case management through San Diego County.
Thank you so much, Karla. Do any other panelists want to comment on that question? Okay, thank you. So our next question is for anyone who has experience with at-home testing kits. How are you navigating getting patients who find out their status at home and attempting to kind of get them linked into care?
I had mentioned that we are doing at-home testing earlier, but we have just started. We have just started this program. Other agencies have been able to do this, and I think we're researching what to do. But I think what we've come up with right now is basically, again, gaining trust with our clients and giving them a roadmap of how this process will go. You will get the test, then I will call you on this date, and then this will happen, and then this will happen. Giving them all of the steps so they know exactly what to look forward to, I think helps build trust, it helps build accountability, and it keeps people kind of on that road. I'll let you know how it goes.
Please do. Thank you, David. Karla, did you want to chime in?
Yes, we have been offering it since June, actually. And at first, we only had a list of clients that had approached us in March that they wanted to get tested. And we told them that there was an agency that was doing drive-through HIV testing in Central San Diego, and we could refer them to that agency during the hours of operations. They said that they wanted to wait, that they didn't feel like they were at risk. They were trying to close that window period, but because they were going to be home quarantined, that they didn't feel that they were exposing themselves, so they wanted to wait for us. When we did roll out the home HIV test, those were the clients that we immediately called because we knew they were trying to close that window period. We did identify, like I mentioned, quite a few positives we've tested from June. It's not a lot that we are testing compared to field outreach. We've tested about 48 of the 48. 7 have turned out to be positives, and all have been linked to care, which does give a high positivity rate. It's just getting the word out through social media, through word of mouth. Our doctors, we are passing out flyers with our doctors, clinics, not just within San Isidro, but partners in the community, that anyone that would like an HIV at-home test, we can personally deliver it to them. We'll coordinate a call, and then our counselors will follow up before they do the test and after they do the test to find out the results and do the status neutral approach. We will refer you to prevention efforts, to PrEP, or to medical care within our HIV specialty clinic. We are looking at expanding that program, getting more staffing available, getting them to become certified counselors in HIV, and hopefully that will bring more clients available to get their home testing.
Wonderful. Thank you, Karla. So we're just about out of time. And again, we have a few more wonderful questions in the chat. So I might reach out to our panelists and ask you all to help me answer those that we haven't had time for during the session. But I just want to take a moment again to really thank all of our presenters and panelists for the wonderful discussion. And also to thank Michelle and Jose from our PACE program for partnering with CHIPS on this session. And most importantly, I really want to thank everyone who participated on the line with us today. Please do look out for an email from me later today with links to the session evaluation form. We really want to hear your perspectives on the session and any suggestions you have for future sessions. And our next Learning Collaborative session is coming up on December 15th, Tuesday, December 15th at 10 a.m. So please save the date for that and look out for more information about that session soon. So thanks again, everyone, and have a great afternoon.